Welcome back to our Science Corner and welcome Tim Fleiner, a German physiotherapist and postdoc, skilled in on physical activity in aging, a topic of really great interest here at Science Corner. Now it's time to get started, and I'd like, Tim, you to introduce yourself.
Yeah, thank you, Nico. Well, my name is Tim. I'm 37 years of age, living in southern of Germany. It's in Ulm, right between Stuttgart and Munich. I'm a physiotherapist, and I've studied sports and movement gerontology. It's at the German Sports University in Cologne, where you can have the master's degrees. And this was followed by a PhD program in the field of exercise and dementia care, where we've introduced an exercise carousel program in geriatric psychiatry, like closed wards in the LVR hospital in Cologne. And now I'm sitting here in Ulm next to our perturbation treadmill, where we're currently working in a falls clinic, working on perturbation exercise for prevention. This is my one half of the position. The second half, I'm working as a physiotherapist.
Okay. I'm in touch with Mark Hirsch too. You know him? No, I think that his paper of some years ago connecting aerobics exercise and increases of brain-derived growth factor is one of the starting point of a lot of research and a lot of mind in the world. And Mark is from Düsseldorf as well, and now is the chief scientist in the Hospital Health with 550 hospital under him. So, as we continue, I know that we are moving into your dissertation topic. Just some words about your dissertation topic. I think it was focused on the effects of physical exercise on neuropsychiatric symptoms in dementia care. I'm very interested in dementia care. I'm getting old as well.
It was a 5-year program I've done there. There is a link between physical inactivity and agitation in patients suffering from dementia. This is from the group of Eggermont and Skerda from the Netherlands, and we saw that the key for good care is physical activation of the people in also closed wards, because we know there's an awareness problem for physical activity, because sedentary behavior, like no moving, causes no burden. But the people who are moving very much, who are running up and down the floor, they cause very much burden. And so they are looked as psychopathological. But we're losing all the other patients that are sitting all the day because they don't care a lot of work. They don't cause a lot of work. And that was our key idea, to get these patients into action, into moving. We were using motion sensors to capture the physical activity of the patient, seeing that they're sitting and lying for 23 hours a day, and don't have that much steps as you need. But also the other hand side, we saw people that were agitated, that had the wandering phenomenon, walking a half marathon on a station ward in a closed station. It's highly psychopathologic. And so this was my program was, one, to capture the physical activity of the patient, and second, to make an intervention program where we were introducing 4 exercise sessions a day for the patient in short bouts, having a carousel approach to come to the patient back, like having half an hour of exercise, 1 hour break, half an hour of light intensity exercise, and going throughout the day in this acute care of geriatric psychiatry. The results were well, for us, nothing new, but was highly significant effects on the neuropsychiatric symptoms. The patients who were more active showed a lower amount of neuropsychiatric symptoms with the same medication. This is for us a good approach that is now gone through the whole stage of care.
Yeah. I don't know if you have opportunity to read. A couple of weeks ago, we appeared the last guidelines of NICE, about
Yeah, yeah.
the quantity of hour. Now, usually we say we have a lot of patients, most of all in stroke, that spend just 2 hours a day, and the afternoon they playing cards. No, intensity is fundamental. So intensity and task oriented is fundamental to get results. So,
And
and
then,
probably technology helps. No,
yeah,
because
yeah, technology helps. Well, we make our patients sit and lie in the hospital. There's nothing to do in there. That's something to have ergometers on the wards, having an active ward strategy. This is something we should move into and make them people active.
yeah, absolutely. I agree. Continuing to move forward, we are seeing that the quantity of papers in these years are increasing day by day. A great interest in the contribution of perturbation treadmill. I know that for the prevention of falls, for the treatment of the neurodegenerative disease, I know that you are competent in this. And what's your point of view? Why you arrived to the perturbation treadmill? And why you're using
Well,
it in the clinic and in the research as well.
well, I think we approach a new era of the fall prevention because we can now go together with the technology to unannounced perturbation that causes slips and trips that are very close to real world falls. And this is something highly effective, shown by the trial by Pi and colleagues, shown by further trials, that only single sessions are effective in a fall preventional approach. And this is something is mind blowing for us, that perhaps we don't need that amount of exercise for having two times or 3 times a week for the fall prevention. Well, they will be frail on the other hand side, or will develop a frailty syndrome. But for the key of the perturbation approach, this is something curious for us, to having each 3 months a perturbation exercise that could help more than 3 times a week per exercise. And that's something I think there's a dose response. We have to now study more and more, and also have a combination for strengthening exercise, for example, and also the nutritional part of it. But we're very wondering, hey, how can we do such technology using in the hospital care, and now getting more and more into research for low amounts, very few amounts of highly intensive exercise on these treadmills.
Yes, I think that the question of the dosage now is one of the question. Even if we know in the daily life that the patient, there is no silver bullet. No,
No.
but we have a lot of technology that can use, and we can try to put together, finding the right mix,
Yeah, for sure. But the technology, this helps us. There's a harness that the patient are secured in there, and
Yeah,
if you do the normal balancing exercise, like the balance test, like a single leg stances, you don't get to the margin of stability.
yeah.
Everyone fixes himself and says, okay, we need to go find a sweet spot where we can bring people into trouble about their balance.
Yeah.
And this is what we see from the real world falls, that this causes a slip, a trip, and only single session is effective.
You have to find the limit.
We'll
You
find
have, you have to find the limit.
yeah,
Absolutely. Absolutely.
go to the limit.
I
Go to the
agree
limit,
with.
yeah.
And in addition, now as a global question, what the roles of technology play in your daily practice, and what GPS now do the clinician use to navigate and choose what not just what is best, what is necessary in your practice?
Well, I like the idea of a GPS in all the information flow, but from my point of view, it's individualization that needs to be the key in all the information flow, because we see it's important to handle, to keep, and to gather out the most important aspects. Also, artificial intelligence helps us to figure out the key elements of the problem, and now trying to see, okay, where are we going to We are very happy to be here in the hospital and also in our ambulatory to work fully digitalized, that we can use all the information, bringing together and personalize the intervention based on the data and based on the experience, based on the patient intention, but also bringing data in to make our work structured and evaluatable. And this is something we are learning more and more also in the physiotherapy ambulance, to work on digital workflows, the assessment, documentation, the reporting. And so I think the next point will also be, or the next step will be, the access point for patient recorded or self-reported data we will bring in, because everyone uses a smartphone, everyone uses an app for example, a pain registration. And this is something we will bring in for getting a better individualization of the treatment, having the personalized medicine into precision.
You just anticipated my next question, so and about what idea of the future. But in the same time, I think that most of all in rehab and physical therapist, you have to touch the patient. No, the patient at the beginning, in certain phase of the therapy of this clinical history, you have to be close to the patient. For this,
Yeah.
a little now so and so about the telerehab. At this moment, telerehab seems a way to save money for the system, most of all.
I agree. We need a starting point. If we see all the pain patients, then we need a starting point. But the next step going towards the independency of the patient is the hands-off therapy, and this is the next step we will address. We're now going to.
Even if we know that aging and post-COVID, I don't know your experience with post-COVID, will bring us a lot of neurodegenerative patients.
Yeah, for sure.
So I have a good news. We have job for the future. There is a job,
yeah, for sure.
But we have to face new challenges. Most of all, the COVID is an highway now for the brain. So, and I believe I have friends that after 6 months, 1 year, still have a slow reaction to life. So there is a great job to do for us. So
yeah, for sure.
Thanks, Tim, for your contribution, and I hope to see you here again in the Science Corner. For all of us, stay tuned and subscribe to the YouTube channel. Bye-bye, Tim. Thanks again.
Thank you, Nico.
Bye.